Hello everyone, this is Chadi Alraies from SCAI 2024. I'm really privileged to be with my friend Jimmy Kerrigan to talk about something everybody speak about now, artificial intelligence in interventional cardiology. Jimmy, thanks for being with us.
Thanks for the opportunity to sit here and to talk about this. I think one of the hot topics at SCAI this year and that we've seen across the board with regards to conferences, ACC, TCT, is how can we leverage computer intelligence, artificial intelligence. I don't really like the term artificial, but using the information that we have in a novel and new way, not only to identify patients who need to come to the cath lab or come in for procedures, but also to optimize those treatment strategies as well. I think that we've seen a lot of vendors who are focusing in on this space. There are more coming every day. We're in Southern California, in a state that's known as a hotbed for AI and for technology. So I'm incredibly excited to see what we're able to do with regards to treating our patients better over the next decades.
From our cardiology field, we have a lot of equipment we use that collect data that can be digitized and utilized. So let's dissect a few of them.
Yeah, absolutely. So speaking of that, so taking the data, dissecting it, getting insights that humans may not be able to find, at least at our center, and we're one of several centers working with a specific company to go through our EMR and to find patients who have under-recognized severe valvular disease. So this goes into our inpatient EMR, our outpatient EMR, our PACS system, looking at the reports and able to identify those patients who have severe mitral regurgitation, severe aortic stenosis, patients who haven't been evaluated by the valve team, in order to put together a best practices prompt to say, hey, we're not going to auto-refer, but this is a patient that might benefit from evaluation. Similarly, and for our EP colleagues looking at patients with atrial fibrillation who've not been evaluated for ablation, the guidelines have changed and that's now preferred. And then for patients with heart failure who aren't on all 4 factors of GDMT, who may not have an ICD, et cetera. So I think that even taking that data, doing much more than what a human could do. I remember as a fellow making spreadsheets for research projects into the wee hours of the morning. Sometimes we still do that, of course. But leveraging AI to get that data to find the right patients to come to us to even be
Especially
evaluated.
busy practice. I mean, you don't have time to go flip through, or sometimes you rush in the clinic. They say, hey, take your Eliquis, see you in 3 months and move on. You forget that this AFib or a DVT or, as you said, ICD not planted yet.
Right. So just finding those opportunities to improve the care for patients. And then once they come to us, what are the next steps? So we use AI in planning procedures in the cath lab. So using CT-FFR in order to figure out not only which vessel is the problem, but if you have multiple lesions in the vessel, which lesion is the problem? How am I going to treat this? Is this a complex proximal LED calcified bifurcation where I might want a 7 French guide? Is this somebody with a depressed ejection fraction where mechanical circulatory support is going to be necessary? Am I at a site of care that doesn't have access to atherectomy, so maybe that diagnostic catheterization needs to be done in another place? Can I have that conversation about cardiac surgery beforehand and know on the table that they're not going to go through with it? So I don't have to bring them back after having the heart team discussion, which is incredibly valid, a class 1 recommendation to have that discussion, but nothing says it has to happen after the angiogram.
100%.
So being able to figure out, again, which patients need to go to the cath lab, who needs surgery, who can be treated medically in a very safe fashion. We know from the ischemia trial. So using artificial intelligence and computer learning to teach us that as well.
Yeah, and fill all these gaps that are missing in the practice or on the table or before planning the procedure.
Absolutely. I think, again, that at the end of the day, we want patients to feel well and live a long time, and we can leverage these technologies to do that.
IVUS OCT is big, as you know, in these conferences, and you're a big advocate for it, for optimized PCI and also for using imaging. So AI and imaging, or AI and OCT IVUS, are we there?
Absolutely. So it depends on the vendor, and as you said, I'm a huge advocate for the use of intravascular imaging, whether it's a second diagonal or the left main. I think intravascular imaging should be part of every procedure, should be a class 1 recommendation. So for the guideline writers out there, please listen to that, hear our appeal. We have so much data that it saves lives. But one of the issues that people say is that I don't know what I'm looking at. It costs too much, it takes too long, it doesn't matter, I don't know what I see. And for that I don't know what I see, we now have artificial intelligence that is commercially available from 2 vendors. So Abbott for OCT and Boston Scientific with automated lesion analysis for the Boston Scientific IVUS. Not to belie any NDAs, but there will be more. So in that instance, we can now tell you where is your proximal reference, where's your distal reference, what are the luminal areas, what are the diameters, and then teaching how to take that information, use it to pick our devices, pick our stent sizes, look in between to decide if we need calcium modification specifically with the Abbott product right now, and then make a determination on not only do I need to fix something, but how am I going to do this optimally so I don't have to come back in and do it again. I don't want to treat in-stent restenosis. That's about 20% of my practice, unfortunately, right now because of brachytherapy. But if we can do it right the first time, using the tools that we have available to teach us that we can do better. We can get to those ultimate trial results.
So you're trying with this is to break the barrier for people. I don't know what I'm looking at.
Yes.
I'm going to just give it to you. Here's your start, here's your end. This is the size.
Right.
Atherectomy, no atherectomy.
Yeah, I think that if you can take away all these barriers, and we're prideful people and hubris, we want to do what's best for the patient.
Yeah.
If it was our mother or grandmother, we want IVUS used in that case, and we've got to take away the barriers that is preventing the uptake in this country. We're so far behind Japan and other countries.
Absolutely. Are these available commercially?
Yes, both Boston and Abbott is available commercially on their current products. Other products will be available soon. So,
awesome.
Stop talking before I get in trouble. Right.
Okay. Thank you so much. A great overview. Again, artificial intelligence for interventional cardiologists from clinic all the way to the PCI and planning a procedure. Thank you so much for your time. Watch these videos and others on SCAI TV. This is Chadi Alraies from Long Beach, SCAI 2024 Scientific Session. Thank you.
Thanks, Chadi.